Good evening, everyone, and thank you for joining us. We are starting at 8 p.m. this evening, but in the interim, until we do, we're having a chat, an informal chat with some of our guests for tonight and some of the people that we'll be seeing later on in this week as well. So a huge welcome to you all, and especially to those of you who chose us rather than the opening of Parliament. But Hirsch, I've just watched the last 45 minutes of our president's speech and the opening of Parliament, and I'm still waiting for him to say anything.
Yeah, Howie, I think not only have we got COVID fatigue, but I think we've got presidential fatigue, and there's a lot of talk, very little substance, and for a nation that needs some reassurance, it wasn't what we were hoping for.
Maybe he's keeping his stuff till the end, but for 45 minutes, I sat there anxiously waiting for something of substance to be said, but so far nothing.
Yeah, absolutely, and disappointing. But look, we've got an unbelievably exciting webinar and a panel tonight, which is going to be incredible. So you know we've got bigger and better things to hear and explore and listen to.
Fantastic. Well, it's a wonderful opportunity to work with the South African Friends of Sheba Medical Center, and we want to welcome our friends all the way across the continent on the other side of Africa and just over into Asia. So Yair, let's unmute you. Welcome.
Thank you, Howard. Thank you for this opportunity for getting our message through. It's lovely to hear your accent. I used to be in South Africa for 16 years, so very nice memories.
Tell us about your links to South Africa.
Sorry, I couldn't hear you.
Tell us about your links to South Africa.
Well, many years ago, I've been there. I was living there for 16 years, doing some. Well, I used to be in the high-tech industry, and worked in a South African company. It was quite an experience, in fact, but it was very close to the Jewish community there as well.
So where in fact did you live in South Africa?
Well, in the beginning in Benoni, and then we moved to Johannesburg.
Shouldn't be so proud to say that, although I'm sure we've got some people from Benoni watching this evening.
I'm sure. I'm a Benoni boy, yeah.
Howie, they say that Benoni, the original name was actually Benoni. So
that's right.
Of Benoni are very close here tonight.
So, Yoel, I see you nodding. Have you ever been to Benoni? Because I don't necessarily recommend it.
I can't remember that I have visited Benoni, but I know the story that Nomi told me about the probably what the original name is coming from, Ben-Oni. So I'm familiar with the story and with the neighborhood, although I never been to Benoni. I've been to other parts of Johannesburg and Cape Town.
So tell us where you join us from this evening.
Actually, right now I'm home, but usually I'm at these hours I'm at the hospital, and this is the time that I'm talking to all my colleagues around the world, especially United States and Canada. So this is the time to speak with them.
So people are going to post into the chat to tell us where in the world they are. We've got amazing viewership in places like Canada and United States and England and France and Israel. Not so big in Australia because of time changes, but we also have people who watch us in Bangkok, people who watch us in Riyadh, Saudi Arabia, in the United Arab Emirates. So we've really turned this platform into a fantastic international education and information and education and entertainment platform as well. So as people post and tell us where in the world they are, I see Belinda is saying hello from London. And we've got people in Cheltendale, people in Durban, a few people in Durban busy telling us. So Michal Beeri, where in the world do you join us from? Erev Tov.
Erev Tov. Let's put it that way. I wish I could be in New York, but I'm happy to be in Israel.
Well, we would much rather have you in Johannesburg than in New York, that's for sure. So where are you in Israel? Because it looks like Israel is in the throes of summer rather than winter at the moment.
That's correct. I'm actually at the office because my dog wouldn't let me speak quietly.
Avner, you look like you dressed much more warmly than your fellow panelists. Where are you joining us from?
I'm from the illustrious city of Ramat Gan in Israel.
Okay, so not so far from where all your other colleagues are.
Very close. 5-minute drive from Sheba.
Okay, and Avichai, where in the world are you?
I'm at home in Rehovot, Israel.
Okay, we're just touching base and finding out. Ohad, can I presume that's your office behind you? Because it looks like you have some medical supplies in the background.
I couldn't hide it. Yes, it is.
So while we're doing that, welcome Leslie. She's in South Africa. Leslie Miller is in Renana. We've got David Glasser in Orlando. Aubrey and Etienne are joining us from Toronto. Linda is in San Diego. From Washington, I can't see who it is from Washington, but welcome where you are. We have Arthur in Johannesburg, Robin in Cape Town, people in London, a few people in London who've welcomed us. So good evening to all of you. A huge welcome. We're going to go live in about 8 minutes time, and we're just going to be doing a little quick informal chat. So Naomi, turn on your camera and let's chat to you as well, because you run the South African Friends of Sheba Medical Center.
Hi, good evening. And thank you so much for giving us this opportunity. I'll thank you again during the program, but I really, really appreciate it. And I'm joining you from Johannesburg.
So first of all, you don't have to thank us at all, because we're all in this together and we don't have egos, which is what makes this platform actually very useful and accessible to everyone. So we're very informal, and we just want to make sure that our audience, and we've had thousands and thousands of people registered for this evening, and we want to give them a little taste and a smell and a feel of what it's like at the bleeding edge of medical research and medical science around the world. And it was amazing, both Yoel and Yair. Last night we were busy chatting. I just watched a webinar by someone called Professor Paul Marek, who is a world expert on Ivermectin. And Ivermectin has become this huge issue in South Africa as we're desperately searching for something that will help us with COVID, because unlike you all in Israel, none of us have been vaccinated yet in South Africa. And our first doses of AstraZeneca vaccines, which arrived this week, prove only 22% effective against the South African variant, the 501V2 variant of COVID. So we're probably going to give back our AstraZeneca vaccines. And in the interim, South Africans are desperately searching for alternatives or something that can give us some hope until vaccines arrive. And of course, listening to Professor Paul Marek, he said, well, there's a research study on ivermectin taking place in Israel that has very interesting results. And so I went online to find where this research was being done. And sure enough, it was being done through Sheba Medical Center. So Yair, at 9 o'clock last night, you were on the phone to Eli Schwartz and saying, will you come onto our webinar? There's no published results since, I think, June of last year telling us what's happening with the research. So a huge thank you to you, and really quite amazing that you managed on such short notice to bring Eli into the conversation and to give us some advice relating to ivermectin this evening. So yeah, thank you so much to you. Can I just ask, who on the panel tonight has been vaccinated and how many vaccines? Michal, how many? You've had 2, Ohad? You've got 5. Oh, two. Avichai 2, Yair 2, Avner 2. My goodness, yes, Hirsch, you and I.
Yeah, we like this, Howie.
Yeah, exactly. We're waiting as they throw away the vaccines that aren't working. If they're only 22% effective, maybe if we have 5, we can get up to 100%. Hirsch?
Listen, it means you can only go out one day every 5. If the vaccine's only 22% effective, you have to stay indoors 4 out of every 5 days.
But does anyone on the panel want to give us some advice about the COVID figures in Israel? Because the one thing that we don't understand is why your numbers, your general infection numbers, are not going down. Is there any logic to any of that other than the fact that maybe the Haredi and the Arab communities are just not adhering to any social distancing? But it seems to make no sense with such a large percentage of the population vaccinated that your numbers continue at enormously high levels. Does anyone who give it a guess? Avner, you look like you may have some insight.
Yeah, just from reading the statistics, and there's some more were just shared a few hours ago, the numbers are beginning to go down. They're going down slower than expected because of the new variants are spreading more quickly, but we are seeing that they're spreading much more within the population that was not vaccinated. So within the vaccinated population, we're seeing very, very nice decline in both overall disease rates and severe diseases. And we're now beginning to see also decline in the overall statistics because we are at the point where I think we're at about 35 to 40% of the population vaccinated, at least with the first vaccine.
That's remarkable. If you follow the international statistics, I mean, I think Israel actually, if you count each dose as a percentage of population per dose, you're sitting at, I think, 58% of the Israeli population vaccinated, which realistically probably is about 38% with at least one dose and probably a good 20-25% with two doses. Followed interestingly by the UAE, Bahrain, and now the United Kingdom. But interesting that there's this little Middle Eastern pocket of progress when it comes to vaccination, which isn't necessarily being replicated in other parts of the world. Maybe it's got to do with small populations, or maybe it's got to do with innovation. And certainly it looks like we've got the right panel this evening to be asking some of those questions or answering some of those questions. So to all of you who are joining us, I see we're having people saying hello to us from amazing places. Joanna is joining us from Germany, people in Cape Town, Gavin is in South Africa, Dee is in Cape Town, Archie says South Africa, Barbara's in East London, Brenda's in Durban, hi from Johannesburg, says Andy, hi from Linda in San Diego. So please drop us a little note in the chat section. We're going to go live in about 2 minutes time. And in the interim, just tell us where in the world you're watching us from. We'd love it that, in fact, we've got such an amazing audience. So Hirsch, you're talking us tonight because you've got a very interesting panel, which you're going to tell us more about just after 8 o'clock, but give us some sort of inkling and taste what you're going to be doing on Saturday night.
Just one point I wanted to just quickly make just around this vaccine. I was thinking about it just in terms of, like in our lifetime, we grew up having, smallpox vaccines and polio vaccines and measles and those were vaccines that were invented however many years ago, and we're in a time again where in a matter of months there's been this new vaccine generated and which is quite amazing. And what we're talking about on Saturday night is, the title is Why Culture Eats Strategy for Breakfast, and I know everyone thinks that this word culture is a big word, and what does it mean? And it's but I think your panel tonight from the Sheba Medical Center, who are at the cutting edge of medicine, the bleeding edge of medicine, there's a culture of innovation and invention. And we're going to be talking about culture in the context of the impact of COVID on organizations, on leadership, and on people, how it's impacted on the relationship between organizations and their people, on leadership, on work, home life balances, the immense stress, the social stress, the mental fatigue, the financial stress. And so that's what we're going to be exploring on Saturday night. We've got a fantastic panel. We've got Richard Sutton, who's been
don't tell us yet, because you're going to go give us a proper punt just after 8 o'clock. Right. And so we've just gone 8 o'clock. A huge welcome to everyone who's watching on both YouTube as well as on Zoom. It is fantastic to be back. For the panelists who are not with us on a regular basis, I spent the last week in the bush looking at some lions and elephants and unbelievable rhinos in a place called Madikwe. The weather was terrible. It had rained there for 3 solid weeks. Everything was flooded. The roads disintegrated. We spent most of our time digging ourselves out of mud in Land Rovers, but it was the most remarkable, fantastic experience. So Yoel, I know you've been to South Africa. Yair, you've been to South Africa. Avichai, Ohad, have you been?
No.
No. Michal, impress us. No. Oh, Normie, you've got a huge job there. Yeah, you have to bring the rest of the team. Avner, you must have been, surely?
Unfortunately, not yet, but I would love to visit.
Okay, well, let's make sure that tonight is the catalyst to bring our friends from Sheba Medical Center to South Africa. So it really is a great privilege to bring you some of the most remarkable scientists in the world at the bleeding edge of medical research. It's such a great pleasure to partner with the Sheba Medical Center and especially the South African friends of Sheba Medical Center in order to give you an insight into what is the cutting edge of medical research in things like Alzheimer's, cancer, COVID research, and what in fact does the future look like for medical practice. So we've got a lot to cover this evening. So welcome to all of you watching. A reminder that if you have any questions for any of the panelists, you'll see at the bottom of your screen a Q&A button. So please click Q&A, and we've got time with each of the panelists to ask some questions. They really are the top scientists in their field in the research that they're talking about. So please feel free to pop a question into the Q&A section if you're on Zoom. If you're on YouTube, please use the comment section in YouTube, and Danny, who's on technical support this evening. So hello, Danny, if you turn on your camera for a second, let's wave at everyone. That's Danny. Danny will in fact be on YouTube passing your questions over onto this panel as well. So questions go into the Q&A. If you want to chat amongst yourselves, comment as we go along, please feel free to use the chat both on YouTube as well as on Zoom. And with that, let's remind you all that it is a great pleasure for the South African Jewish Report to have now brought you 75 webinars since, or 74 webinars since lockdown began. So Hirsch, on Saturday night, we're on number 75. We're counting anxiously.
Yeah, it's an amazing milestone, and that's in less than 12 months. So as I mentioned, the title of the webinar is Why Culture Eats Strategy for Breakfast. We're going to be talking about the impact of COVID on the work environment, on leadership, on organizations, on people, the relationship between organizations and people, just given the immense stress and mental fatigue that is in our environment at the moment. And we've got a fantastic panel. We've got Richard Sutton. Some of you may have seen him grace the center courts of Wimbledon as a wellness and advisor to the likes of Kevin Anderson and Maria Sharapova. He now advises corporates and has just released a book called Stress Code and Stress Proof. So he'll be talking to us about stress and how to alleviate stress. And he's just brought out a new app where you can manage your own stress and your own lifestyle. We've got Greg Solomons, who's the CEO of McDonald's, and he's going to talk to us on the ground about how he has led his 16,000 employees across the country through an extremely difficult time for the food industry. We've got Professor Corinne Milner, who's an associate professor of organizational psychology. And she'll talk obviously about the impact of isolation, working from home, and the stresses that people are going through. And then we've got Amanda Porto, who is the head of culture at a South African icon of a company of discovery. And she's going to be talking about some of the things they're doing in their organization and what leaders are having to deal with in the current environment.
So Hirsch, thank you. We'll see you 8:30 on Saturday night. We start a little later on Saturday evenings. So those people in Cape Town where Shabbat comes out a bit later are able to join us in time. So we'll see you 8:30 Saturday evening. Hirsch, thank you for joining us.
Thanks, Howie. All the best for the panel.
Thank you. And just a reminder, the latest edition of the South African Jewish Report is now out. There's a remarkable story on the front cover relating to arsonists. They in the Kruger Park, in fact, killed a poacher who was poaching animals in the Kruger Park, and the local community decided to take revenge on a lodge just next to Kruger, owned by Jewish owners, and burnt the entire lodge down, all 40 rooms in the lodge, the conference center, the buildings. It's going to have a devastating impact on the entire area because so many in the local community were employed at the lodge. That's our lead story this week. It's an amazing edition. Please go either pick it up at your local Checkers, Pick and Pay, supermarket, discount pharmacy, in your garage shop, in exclusive books, in CNA. We're absolutely everywhere. But if you're not going out, if you're staying isolated at home, then go on to www.sajr.co.za. That's sajr.co.za, and you can download the full edition of the Jewish Report, or alternatively, you can look at each of the articles individually and check out what really is an amazing, amazing edition this week. And with that, we would like to start with Yoel. I'm going to ask everyone else to turn off their cameras, and Yoel, you and I will stay on for a few minutes. But before we do that, we've got a very short video to give people some background information of exactly who Sheba Medical Center is. We're going to play that, and then we're going to come back and you're going to give us a little bit of background.
Only those who know how the day starts, but not how it ends. Who tried, succeeded, then tried again. Those who worried. Those who did not give up. Those who felt the weight of responsibility on their shoulders. Only those who saw the end and realized it was only the beginning. Who brought new life into the world, who've tasted victory, those who constantly seek out the next discovery, those who believed, only those who slept 2 hours a night, who removed all social barriers, who kept their cool, those who dared, supported, protected, laughed, made others laugh, pioneered. Only those who broke new ground, who wake up every morning to carve a new path. Only they understand. Hope has no boundaries. Sheba Tel HaShomer, City of Health.
So, Yoel, tell us a little about Sheba. Where does it come from? How did it suddenly come to such degree of prominence around the world as a cutting-edge medical research facility?
So first, Howard, allow me to thank you and the South African Jewish Report for having us in this special evening. Sheba Medical Center became, in the last 72 years, the largest and the most comprehensive medical center in Israel. Actually, it's not a hospital, it's a medical center that combine 4 big hospitals, the acute care, the OBGYN, the kids, and a huge rehabilitation center due to the, mainly to the army casualties that are bringing to Sheba to rehabilitate. And I joined Sheba 4.5 years ago, together with the CEO, Professor Yitzhak Rice. We inherited an empire. This empire was built on the giant's shoulders of Professor Chaim Sheba, the first founder, later Professor Mordechai Shani, Professor Rothstein. And I think the DNA of this organization from the roots, from the very first beginning, was sitting on I would say 4 pillars. One is getting the best medical care that they could at the time, the people of the state of Israel and for the neighbors around us. The second one is cutting edge research. The third one is highly educated education system. And the 4 pillar is always extending a hand to people in need. It can be in Israel, but it can be around the world. And from very beginning, Sheba used to send troopers, nurses, physicians to help Bedouin in Sinai, to Greece. And my team just recently came from Italy where 21 Sheba troopers, we call them troopers, support and assist Piemonte Hospital in the northern part of Italy, where they suffer from severe cases and the ICU units were occupied and the staff went into a huge fatigue problem. So I think those 4 elements of Sheba DNA brought Sheba to the place that we are standing right now, which the 2nd year in a row, and I hopefully, if you will call me next month, I can tell you that it's the 3rd year in a row Sheba was placed in the list of the 10 top hospitals in the world, a ranking by the Newsweek magazine.
That's quite amazing. Just give us a sense, how big, what's the staff complement, how much research is happening there?
So, you know, size and numbers are very impressive, but not always so, this is not the main issue. Last year, I was giving a lecture in Monaco, and I want to demonstrate the size of Sheba Medical Center. And I figured out that at the end of the day, Sheba campus is the half of the size of Monaco. And for our American audience, this is our campus is bigger than the campus of UCLA. So it's a huge facility in the heart of Dan area, actually very, very close to Bar Ilan University. More than almost 10,000 employers, 17,000 physicians, and 25,000 cars entering every day to Sheba, 1.6 Israelis getting medical services. And if you understand the population of Israel, you probably figure it out that between 10 to 15% of the population is moving and running through our gates every year. So it's a huge facility with a huge footprint on Israeli society and healthcare scene in Israel.
Well, that's fantastic. We're so grateful to you for providing really a star-studded team this evening of medical researchers. And we really so look forward to dealing more with Sheba in the years to come. So, Yoel, thank you so much for joining us this evening, and really appreciate all of your efforts that you do. And I know there are many South Africans who've gone to Sheba for treatment as well, and for the support you have led to people like Kolani Gwala, who is a very famous South African radio host in South Africa, who in fact was progressing very well at Sheba until he came back to South Africa. For the eternal gratitude.
Right. Yeah, absolutely, you're right. And I think what makes it very interesting, the story between Sheba and South Africa, that, you know, all through the 72 years of getting immigration from South Africa, finest physician came to Sheba from the very first. From the era of establishment until recently, finest physicians, finest nurses are coming and working at Sheba, like Professor Talia Golan, like Professors Tzvi Zayman, and they are really the top researchers and top physicians. And some of my colleagues that you will hear tonight also on the top of the edge of their activities at Sheba regarding cancer, regarding brain research, and I won't take the stage from them, but we prepare a very nice and detailed program for you. And I'm also hoping that Professor Eli Schwartz will be able to give you, I think, worldwide scoop for tonight about his research with the Ivermectin. So I hope you will enjoy the program tonight.
Thanks, Yoel. We'll see you a little later. Thank you for joining us this evening.
Thank you very much. Thank you, Harold.
Michal, a huge welcome to you. Lovely to see you. Thank you for joining us. You are a world authority on Alzheimer's research. But before we begin, I have to ask a question. Wherever you go, there seems to be more and more Alzheimer's all over the place. Is it because we're living longer as humans, and ultimately, will we all, if we live long enough, land up getting Alzheimer's?
So you're going to have to listen to my presentation to get an answer.
Okay, the floor is absolutely yours. Please go ahead.
Okay, so I'm just going to share my presentation. And let's do this. Here we go. Yeah, those who I can see, can you see the presentation clearly?
Yes, we can.
Okay, so I'll begin. So first of all, it is a pleasure and exciting, and I've been speaking all around the world, but I haven't spoken to South Africa yet. So this is very exciting. I really would have hoped and wished to do it face to face, as I am sure it would be a lot of fun and interesting for me. In any case, the focus of my presentation is going to be about prevention of Alzheimer's disease. I'm going to try to make a point for why that should be the pathway that we scientists should take, and with some focus on the startup country, startup nation, which is Israel, and you'll understand why. I've been given 20 minutes, which is a short time to talk about many things. So be with me, try to be focused on what I'm saying. And I understand there will be time and space for questions, which I'll, of course, will be very happy to answer. So I'll begin just giving a short overview of what Alzheimer's disease is. How do we diagnose it? So it is a memory problem. It is a disease of memory impairment that has to be formally and objectively measured. So many people that complain say, oh, I'm forgetting words, or I'm forgetting names. That's the most common one. I forget where I put things. Those are subjective memory complaints. They're not sufficient, and most probably they're irrelevant to the disease. Now, memory problems are not enough. We're expecting to see, from a diagnostic point of view, at least one more cognitive domain that is affected. For example, orientation in space, orientation in time, executive functions that are affected, executive functions that are high functions, such as understanding sense of humor, being able to make a decision, all right? So we need a memory, an objective memory impairment plus an objective impairment in at least one other cognitive domain. We do need to see a clear deterioration compared to the past, all right? So people who have, like me, unfortunately, a terrible orientation in space for all their life, this is not deterioration, that's a status quo for them. We typically will hear sentences or comments from the families like, if you only knew what she was before, or he was brilliant, something that makes it clear that it's a deterioration from a prior state. We do expect to see clear impairment in social, professional, and day-to-day functions. And the professional piece is actually interesting because it relates to the shift in demographics. And as Howard was saying before, in the aging process, people 20 years ago stopped working at the age of 6 or 65, and that was it. Now people continue working because many people live to their 90s and 100, and people working until very late. So in fact, until 10, 20 years ago, most people would come to a memory clinic because family members were realizing that the patient is developing something. Today, actually, because people work into their older ages, we get a word from colleagues in the offices or at work of the patient who's developing the disease. And then finally, we want to make sure that it's not something else, right? That it's not a significant B12 deficiency, that it's not a stroke, it's not a tumor or something else. Yeah, this graph is a very painful graph. And here's my answer to you with regard, if we get old enough, will we all be demented? And the question is almost yes, okay? Almost yes. I don't want to say a full yes because that wouldn't be true. But if you can follow my mouse, I hope you can see it. At the age of 65 to 69, about 5% of the people will have dementia. Okay, let me just take 1 minute to explain the difference between Alzheimer's disease and dementia because people do get confused. So dementia is an umbrella name for many diseases that clinically look similar to Alzheimer's disease, but the pathology in the brain is different. Now, if we take 100 people who have dementia, 70 or so of them will have the pathology of Alzheimer's disease in their brain, and I'm going to show you what that means in a minute. And then the other 30 will have other kind of pathologies. About 15% will have brain vessel disease pathology, cerebrovascular pathology, that would be vascular dementia, but then Parkinson's disease kind of dementia, Lewy body dementia, Pick's dementia, other types of pathologies. But the vast majority of the people who have dementia have the pathology of Alzheimer's disease in their brain, and this is why people get confused. So here in this graph, the purple and green is a mix of all dementias. If you look at 85 to 89, it's half. Now pay attention to what I'm going to say now, because this is, for me, every time impactful again and again and again. If you take 100 people over the age of 85, and keep in mind that in the Western world and the developed world, those above the age of 85 are the fastest growing segment of the population, half of them will have some kind of dementia. Now, if in the past we thought that that trend will kind of plateau, because if you made it to 90, then without dementia, then you won't have dementia, that unfortunately is not true. And dementia prevalence keeps going up and up. Not everybody becomes demented, but the vast majority will have dementia if we make it to very old age. Since most of us want to make it to very old age, we want to make it healthy. And this is the main point of my presentation today. So here is a major problem, all right? In the last decade or 12 years, about 460 molecules have been tested for the treatment of Alzheimer's disease, and none worked. None worked. Now I'm going to walk you through a little bit of what those medications were trying to address or were trying to target. And then I'll try to explain at least main reasons for why have we failed, okay? So the two main pathologies characterizing the brain of an Alzheimer's patient are called amyloid plaques and neurofibrillary tangles. Amyloid plaques are here on your upper left side of the slide. And those are aggregates of a protein called amyloid that aggregate in between neuronal cells and in between the brain nerve cells. And when they're growing in there, the cells cannot communicate and start dying, all right? And they accumulate over time. And this is why one of the reasons why Alzheimer's disease develops. The neurofibrillary tangles actually are proteins. They're proteins that hold the shape of the brain cell, and they become ill, and the cell collapses, okay, and dies, and that's the second main pathology. There are other pathologies. This is, by the way, the activated microglia is from our own microscope, which is very cool. So those are immune cells that their job is, among many other things, is to chop amyloid, which is those little orange colored little thingies. And they're doing it when they're happy and healthy. They do it very effectively. They see amyloid, they chop it. And this is real. I mean, this is real microscopic picture from our group. And in Alzheimer's disease, those microglia do not do their job well and become incapacitated. The last thing I want to show you in this slide, because it is important, is on your bottom right, you'll see a word here at the bottom called acetylcholine, which is the neurotransmitter, one of the chemicals in the brain that becomes affected by Alzheimer's disease and is very low in the disease. Most of the medications today, there are 4 medications in the market to treat Alzheimer's disease. 3 of them are based on this mechanism, meaning that when you take them, the levels of acetylcholine go up in your brain. They do improve in about 30% of the patients, somewhat the symptoms, a bit, but they don't change the course of disease. Therefore, they're not effective enough, and this is why we're all so desperate to find something better. So then I go back to what I promised before, which is the why. Why have we failed to find a medication for Alzheimer's disease? So the first main reason is simple. There is nothing in the whole universe that compares in any possible way to the complexity of the brain. And this is why the brain is so enormously, endlessly exciting. All right, so that's the main reason, not only for Alzheimer's disease, but for any disease of the brain. There aren't cures, okay? There are symptomatic treatments, but no cures. Now, specifically to the issue of Alzheimer's disease, I picked 3 reasons. There are many reasons why we might be failing, but I picked 3 to make the point that I want to make towards the end of this presentation. The first is genetic heterogeneity. When we do a clinical trial, we bring 6,000 people, half of them take the medication, the experimental medication, the other half get a placebo, and we don't necessarily take into account their genetic background. Now, if you think of, let's say, breast cancer, right? In breast cancer today, we know that much of the personalizing the treatment for the woman who has breast cancer has to do with her genetic background. So this is something that our scientific milieu is addressing. The second potential reason is that we might not be hitting the right biological target. So I showed you a few of them, right? Primarily amyloid and neurofibrillary tangles. The protein behind them is called tau. And it is possible that there are other pathologies, or there are interactions between pathologies, and this is why we're not getting it right. But there is a third reason, which I find crucial, and it has to do with the next slide. This line here at the bottom, the dotted black line, is similar to the first graph that I show you, that the prevalence of Alzheimer's disease grows with age. So you can see that here in your 60s, there is very low prevalence of Alzheimer's disease, and at the 80s, it's already hitting half of the population. Now, the black hard line, that's amyloid pathology. Now, mind you, please, that this is not a conceptual model. This is data. This is evidence. People begin developing amyloid in their brain in their 40s, 50s, and 60s. And it takes about 20 to 30 years for the symptoms to really show. The clinical trials have been primarily addressing people already ascertained with Alzheimer's disease, meaning 20 to 30 years after their pathology started aggregating. In other words, their brain is mush. So our main goal is actually to get people in this stage when the pathology is only beginning, and stop it right there. And I'll tell you a little bit how we're hoping to do it. This is just a tiny little background. Age, sex, and genetics are related to Alzheimer's disease. Age I showed you before. If I could see you, I would ask you if you think that men or women have more Alzheimer's disease. But since I can't see anybody except for myself, which is a shame, female women have about two-thirds of the cases of Alzheimer's disease. And if anybody has questions about this, I can address it when we have time for questions. And those are modifiable risk factors, okay? Those are 7 risk factors that have been repeatedly shown in different areas of the world with different technologies, with different measurements, that they predict the risk of Alzheimer's disease. And those are low physical activity, so couch potato, no good, obesity, hypertension, diabetes, smoking, low cognitive activity, and depression. There are a few clinical trials, there are many going on, but a few that have been published already, that actually took thousands of people and addressed those risk factors, thousands of people, and gave them to go to classes or something that would be interesting for them to participate, but wouldn't address directly those risk factors, and follow them, their cognition, for several years. And those clinical trials are suggesting, many others have to be done and are being done, but are suggestive of a slow rate of decline in those whose risk factors are being treated. Now, please pay attention to what I'm saying, okay? I told you 460 molecules, medications, did not work, but addressing risk factors or preventing them altogether is delaying the rate of decline. Now, this is important because people want a magic pill. People want a pill that will work as if they did physical activity, and if they dieted, and if, right? So I am telling everybody, please pay attention. Prevention of those risk factors may well delay your rate of cognitive decline. And yet, we want to find a medication. By the way, the World Health Organization has defined about 2 years ago, has defined dementia prevention recommendations. If you get into their website, you'll find it. It's some 180 pages, but they have a summary that would give you a good sense of what their recommendations are. So in light of what I've said so far, our major scientific goal at Sheba in terms of Alzheimer's disease is a little complex, but bear with me and I will walk you through it, okay? So we want to find technologies that can identify the very earliest steps of the disease, okay? those stages at the 40s and the 50s when people are working and completely functional, but maybe there are ways of discovering very, very subtle changes that are happening already there. But then in parallel, we want to find the biological changes underlying those first behavioral changes. Okay, now why is that important? Because then we can develop interventions that are given in the optimal window of opportunity. I showed you that when they're given when a person has already the disease, it does not help. It's not working. But if we give them right at the beginning, when the beginning of something is happening, then we have the potential to stop it, if we're lucky enough, or at least to push it away in a few decades. And getting demented at the age of 105 is better than at the age of 75. I believe that most of you would be doing like this with your heads now. Let me just mention one more issue here, which is important. Many people ask me. People say, wait a minute, if there are no medications, no solution for Alzheimer's disease yet, why would I want to know that I have potentially Alzheimer's disease at the age of 42? And that's a very legitimate question. But I want to give, first of all, people have the right not to know. Let's begin by that. But there's a few advantages of knowing. The first one is that you can plan. The second is that you can adopt every possible preventive measure that is out now in the scientific world. And the third is that you become an active potential participant for any clinical trial for prevention. And as I said, there are many beginning because we believe that's a major and important pathway to intervene. But the other part of it is something that people have difficulty understanding. The most important thing is not the biology. The most important thing is the outcome of the biology. If I have one neuron in my brain, but it's working perfectly well and I have no trouble functioning, then be it. But if my behavior with a gazillion neurons is not good, or the memory is not good, I want to understand what is that behavior that this biology is harming. And this is why those two have to go in parallel all the time. And now I'll tell you how we're doing it, okay? And I'll give you just a few examples because I know I'm short in time, but we call it our Alzheimer's Breakthrough Program. And as I said, defining the earliest biological changes in Alzheimer's disease while defining the earliest behavioral and cognitive changes of Alzheimer's disease. And I'll go directly here just to save time. I'm going to give you an example of two technologies that we have been working with, okay? Two important things to say with regard to those technologies. The first one, just for full, total, complete transparency, I have zero conflict of interest. My only conflict of interest with those companies is that I love them because they're fun people to work with. They're creative, they're excited, they're proactive. They have the primary goal of helping other people in the world, and that makes me happy and touches my heart and my mind. And the second thing that is important to say is that in Israel, it's quite incredible because every day someone knocks my door with a new technology. In fact, a lot of my job has been the last few years to do some basic due diligence and not to see everybody, because otherwise this will be everything I'm going to be doing. So I picked two because we have a lot of data on them that I can show you, which I find exciting, okay? One of them is called RetiSpec, and it's actually a camera that looks into your retina. Now, your retina is a protrusion of your brain, and the retina has many features that look like the brain. It happens that the retina builds up that amyloid that I've been talking about. And what we have been showing in our first data, there is a lot of work to do there, but it's exciting, okay? It's exciting, is that people with mild cognitive impairment show in their retina, show more amyloid than people who are cognitively normal. Now think that we could have, if this works out, we could put it in every doctor's clinic, theoretically speaking, and make sure that people are not building this up. If something is going on, boom, we intervene with whatever we have that moment. The other technology I want to show you is, this graph is something that we produced yesterday because I was very excited to see the data. So this is actually passive technology, all right? This is a cell phone technology. We download an app. This company is called Mind You. We download an app. And the app actually takes information about speech without the contents. By the way, they deplete the content. So it's mainly everything that has to do with the fluency of your voice, of your speech, but not the content itself. And everything that has to do with your reaction time, amount of space you use, everything that the phone sensors can gather. What we did here was to take about 80 people who agreed to participate in this study. We gave them phones with the app, and they used those phones just regularly like everybody uses. And during 6 months, we collected all this data that the sensors were collecting. Okay, again, there is no content collected. Sometimes people get paranoid about it. No reason to be paranoid. But we collected information about their behavior, their cognitive behavior, let's call it that way, throughout 6 months, and correlated it with the hippocampus. The hippocampus is a little region in the brain, both sides, around our ears, about 1 or 2 centimeters inside, an inch for those who like inches better than centimeters. And that area is responsible, is the first area affected by Alzheimer's disease and is responsible for memory retention. And what we're showing, think conceptually about what I'm saying, that information that we collect through the phone about our behavior is nicely correlated with the size of our hippocampus. Now, remember what I said before, we want to try to find simple ways to address little tiny changes that might reflect a major change over time. And this seems to be also a good direction to take. We're very excited about it. And now, almost to finalize, also an example of biological, very, very early biological alterations, okay? A main direction that we have been taking is called omics, okay? Some people might have heard proteomics, genomics, people might have heard. So if in the past, let's say, people would look, we scientists would look at a particular protein that has to do, for example, with amyloid degradation, breaking out the amyloid, we would work a medication around that protein. But we today not only understand, but also have the technology to understand that the human body, and definitely the human brain, is so much more complex than one protein or a pathway of some proteins, right? It has gazillions of proteins that interact and speak with each other and that are affected by other proteins and so on. So what the little example, just almost to finalize, is that we're now there are many omics, okay? Metabolomics, lipidomics, et cetera, And the example I'm giving you now is an example based on glycoproteomics, very, very novel, I have to say. So proteins are also affected by glucose molecules that do things to them that make their function be better or worse. And what we have found, and still this has to be replicated, is that in people we took 2 groups of people, 2 groups that had no dementia, nothing, at the beginning, cognitively intact. We followed them over time and we took bloods from them. And we're measuring this glycoproteome on them. And we're finding a set of proteins that are changing over time as in the people who are declining cognitively, but staying stable and well in people who are not declining. Now think conceptually that if that is replicated and we do some more research to understand if that is really true and works well, then there is a new direction of medications that we want to take. So to finalize, I always put this slide. So if you ever were in my presentations, you will know her. You'll understand why in a minute. This is Madame Jean-Louis Calment. She died at 122. She was the record of longevity then. I think today there is there is a record for a Japanese woman that is 125. But the reason why this woman is so cool is because she started fencing at the age of 85, and she biked until she was 100, and she smoked 2 cigarettes only until she was 117. And I keep asking myself again and again, what made her stop smoking at the age of 117? And then she drank port wine every day. And the one that I definitely most love, she ate 2.5 pounds of chocolate every week. That's a pack of chocolate every day. All right. Now, the reason why I'm so excited about her is that woman died in her sleep at the age of 122. She was functional until the age of her death. And this is our goal for the world. Thank you very much.
Michal, thank you so much. I see there's so many questions that have come in for you. We've got about 10 minutes for questions, so I'm going to kind of almost do rapid fire. If we can do quick question, quick answer. Let's take the presentation off the screen, so if you can stop sharing so people can actually see you, and I'm going to try to pose some of these questions to you. So the first one comes in from Lisa Shevitz, who's actually in East London, and she said, I've just read about a new drug from Cassava Sciences, and I'm going to butcher the name, but it's Simufilm, to improve patients' cognitive skills and help with Alzheimer's. Any thoughts on this, or is it too early to tell?
Okay, so let me say two things. If I'm not mistaken, they just finished their phase 2, so they still have a way to go. There is a tendency, which I'm not going to get into here, for phase 2s to do well, and then when we go to the next phase, when it's out of the original place where the medication was developed, to do a little less well, okay? So this is optimistic, we're happy about it, but many medications that have gone to that stage, when they went to the big stage of doing it across the world in different centers, they didn't succeed. In that regard, I do want to mention there is another medication called aducanumab, Biogen is the one that developed it, that they had in the small study, they did well. In their big study, they did not do well. They did do 2 big studies. One of them did well and the other didn't. They have now shown the FDA new evidence suggesting that they are effective in degrading amyloid and maintaining cognition. We're going to have to wait a little bit. But if the FDA approves it, there is a lot of criticism, but if the FDA approves it, it will be the first medication that changes the course of disease that will be approved in the market, which will be interesting to see.
So, Michal, it looks like we have a few doctors online, and we have a few questions about the Bredesen protocol for Alzheimer's, whether you have any comment on that.
About
Dr.
what?
Dale,
I didn't understand.
It's from Dr. Dale Bredesen, his work and the Bredesen protocols for Alzheimer's.
Yeah, so I'm sorry, but I wouldn't know the answer.
Okay. From Ethel Phillips, she wants to know, is Alzheimer's reversible at all with anything that we can do at the moment?
Okay. It's a tough question for me to answer, okay? If I'm not politically correct, I would say that at the time the disease is already ascertained, it is probably too late. If there's some scientists, especially in the US, that suggest that there are certain protocols that involve really a very comprehensive intervention with the patient, from nutrition to physical activity, really taking in a very holistic way the patient, that they believe that there is a way to somewhat reversing the course of disease. I have to say that in my opinion, there is still a lot to show there to be convincing. In terms of taking the beginning of the disease, those very early stages, and possibly reversing it, we still have to show evidence for that. But I think that would be much easier to do because the neurons are not going to be dead yet.
So a question that's come in as well is there any link between macular degeneration and Alzheimer's?
No. The answer is, I want to say no. So far, no association between macular degeneration and Alzheimer's disease. There is some literature on cataract. There is some literature in general on low vision. In fact, I just accepted a paper in neurology showing that there is association between low vision and Alzheimer's disease. But I do have to say that we have to be very careful with interpreting those results. And the reason is that the way we test today, cognition requires a lot of vision and requires hearing. So when the senses are low, many times it will look like the patient has an impairment, while in de facto the patient doesn't. And this is one of the reasons why those passive technologies may become so important.
There's a similar question relating to insulin resistance, whether there's any connection between that and
something that I'm very curious about is the brain, especially the cortex, which let's say in the simple words would be the gray matter, right, is filled with insulin receptors. The brain depends on insulin, and memory depends on insulin. Now, the only source of insulin in our body is the pancreas, which makes it very interesting that the brain cannot work well if the pancreas is not working well. So absolutely, people with insulin resistance have a high risk. In fact, insulin resistance, as I showed obesity and diabetes, obesity leads to insulin resistance, and insulin resistance comes before diabetes. So definitely it's in the same pathway.
So one of the things you didn't touch on is genetics. If you have a family member, a mother, an aunt, a grandmother who had Alzheimer's, are you at greater risk of actually getting the disease?
Okay, this is an important question. Many people get nervous about it, right? So I want to divide the answer into two little pieces. The first one is what we call early onset Alzheimer's disease, okay? So early onset Alzheimer's disease typically happens before the age of 60, most often the age of 40, 45, 50. Those who watch Still Alice, the movie, she had early onset Alzheimer's disease. There are 3 genes that have been discovered, 3 mutations that have been discovered that cause early onset Alzheimer's disease. They are rare, okay? 1 to 3% of all Alzheimer's disease patients are due to those mutations. And those are what's called autosomal dominant mutations. If you have it, you'll get it. If you have the mutation, half of your kids will have it. So that's early onset Alzheimer's disease, very aggressive disease. Late onset Alzheimer's disease is all the other cases. There is a genetic influence. There is a gene, a particular risk gene called ApoE, that if you have the 4 type, you're at a consistently increased risk of having the disease. But to date, there have 25, let's call it SNPs, 25 genes have been discovered to be implicated in the disease. And it seems that the more you have the wrong genotype, right, the genotype of risk, you're at higher risk of developing the disease. All that said, here's something important to know. The genetics of the disease have to do with the age that the person developed the disease. So if a person developed the disease at the age of 65, that person's first degree family members will have a higher risk of developing the disease than if the person developed the disease at the age of 85. And in fact, we have data showing that if the person developed the disease, made it to the age of 90, when I remind you, they have over 50% chance of developing Alzheimer's disease. So if a person made it to 92, 93 without developing Alzheimer's disease, then there is no genetic risk for their first degree family members.
So Michal, I'm going to do 2 more questions before we move on. Although there's a huge slew that has come in, but Monica Davidovici, who's an ophthalmologist in Johannesburg, says, is there evidence of a connection between glaucoma and Alzheimer's, in particular OCT of the optic nerve and retinal fibers and Alzheimer's? Can you comment briefly, please?
Sure. So there is no robust evidence about glaucoma, but there is significant evidence, including in our hands, that there is thickening of the retinal layers in the beginning of the process of the disease, and as the disease progresses, there is thinning. Okay, the thickening is probably because of an inflammatory reaction, and then slowly the cells die. So the answer about glaucoma is that not necessarily, but in general, the thickness of the retinal layers seem to be related to the early stages of the disease. And this is why the retina is so exciting.
So once again, connections, nocturnal oxygen desaturated association with sleep obstructive apnea. Any connection to Alzheimer's?
Okay. So yes, again, I am not familiar with any clinical trial that tried to put people on CPAP or something to stop sleep apnea. but there is evidence suggesting that people with sleep apnea have poor cognition. Yes.
Okay, and the last question I'm going to ask you, there have been a few questions about RNA vaccines and whether RNA vaccines may have any implication for Alzheimer's.
So the answer is that there is zero data about it. I keep following this very, very closely because we want to know that our patients, when they're vaccinated, they're not we're not increasing the risk for mortality, for deterioration, and there is zero evidence so far, zero.
So Michal, to summarize, give us 30 seconds of advice. What do we do tomorrow to change our lives and our lifestyles to make sure we don't get it or delay the onset of it and that we can live full and healthy lives for as long as possible?
You know, I keep thinking what to tell my mom, myself, my husband, right? And I think that I'm going to say something that is not comfortable, but is good for life in general and definitely good for the brain. Don't be on your comfort zone. Every time you're on your comfort zone, just get out of it. If you exercise in a particular way, take another half a mile. If you stopped eating chocolate, which for me is more or less committing suicide, just a tiny little less than that. If you're learning a new language and it's coming easy, take a language that makes it difficult for you. Everything to make that a tiny little extra effort all the time, incrementally, will, based on the current data, probably help you slow down that path if you're in it.
Michal, thank you so much for joining us this evening. It's been so enlightening, but more importantly, we look forward to hosting you in South Africa. It's been truly an amazing and insightful lecture. Thank you so much for joining us.
I appreciate it. My pleasure. Thank you.
Thank you. Avichai, you got some very big shoes to fill there, don't you think?
Sorry?
I say after Michal, it's not easy to go after a presentation like that.
Well, it's a different era.
So Avichai, your area of expertise is in fact cancer, and you're going to be talking us about CAR T cells. Now, just before you start your presentation, I think before coronavirus hit and we all became experts by reading medical information on Facebook, no one had ever heard of a T cell. But you're going to take us on a journey and explain to us about T cells, how T cells work, why they're not effective against cancer generally, and what you can redo to reboot a T cell to make sure that it in fact becomes a cancer-fighting cell.
I will try in the 10 minutes I have to show you lots of CAR T cells that are one of the newest therapies in treatment cancer, and majorly hematologic cancer and lymphomas, actually.
Fantastic. So, thank you, Avichai.
How it's done.
The floor is yours. Thank you.
Okay, this is my slides. I hope we can see that.
Yes, we can.
Yes. Okay, so what are CAR T cells? These T cells are cells of the immune system that attacks bacteria, viruses, and also cancer. And CAR T cells are T cells that are produced outside our body and engineered by techniques of new techniques of genetic engineering to be killers of cancers. And I will show you some data on that. And I will focus on a disease, cancer of the immune cells called diffuse large B-cell lymphoma. This is the most common type of lymphoma, cancer of the immune system, and particularly of the B cells. There are two kinds of lymphocytes, B cells and T cells. The T cells are the effectors of the immune system. The B cells are those that ultimately produce the immunoglobulins, and they can become cancer. And the most common cancer of the immune system is diffuse large B-cell lymphoma. With modern chemotherapy, about 60% of patients are cured with initial modern therapy. But what happened with the others. So if we start with 300 patients with diffuse large B-cell lymphoma, about 2/3 will be cured with the current therapy. But the other third, let's say here in this algorithm, 100 patients will have a disease that either do not respond to initial chemotherapy or recurs after initial treatment. And these patients are usually treated with what is called salvage chemotherapy, strong chemotherapy, and followed by stem cell transplant, an autologous stem cell transplant, autologous meaning transplants from the patient's own cells. And this is based on giving the patient high doses of chemotherapy. But out of these 100 patients, only about 50 will be eligible for such an aggressive treatment, the autologous transplant. The others will be either too old or too frail, or may have comorbidities that preclude them from having this type of transplant, type of treatment. So we are now staying with 50 out of these 100. These 50 patients will get salvage chemotherapy, but only half of them will respond. And response to salvage chemotherapy is a prerequisite to go for an autologous transplant. So the others will not respond. And out of these 25 that will go to transplant, only about 10 to 20 will be cured, and the others will have recurrent disease. So for these patients that are not cured with initial therapy of diffuse large B-cell lymphoma, only about 10%, 10 to 20% will achieve long-term survival with standard treatments. And I will ask you to remember these numbers in order to see how this has changed in the last few years. So in a large study looking at several hundreds of patients with recurrent or refractory diffuse large B-cell lymphoma, only about 10 to 20% were alive at 2 years after the diagnosis, and the median survival was only 6 months. So we come to the CAR T cell. What is CAR? CAR is for chimeric antigen receptor. So this is difficult to understand. I'll try to explain it simply. You take the patient's T cells, immune cells, and you engineer them to attack the lymphoma. The T cell here in green has a receptor that directs it against what it is directed for. But here we engineer the patient T cells to express a receptor, a chimeric receptor, chimeric meaning that it is from 2 species. The receptor is taken from a mouse, and this receptor is against a protein called CD19. CD19 is a universal protein expressed on most B cells, including lymphoma. So now we put this mouse part here with some other components that will make the T cell work. And here we have a CAR, a chimeric antigen receptor T cell, that is directed directly against lymphoma that express the protein CD19. So this is treatment with the immune system, not like we used to do in cancer with chemotherapy, but with the immune system. So there are 2 types of CAR T cells against lymphoma that are already approved by the FDA and other authorities. The names are unpronounceable, but the trade names are Yescarta from Gilead or Kite and Kymriah from Novartis. There are certain differences between these 2 products, but that will not go into. And there is another product that is going to be soon approved by a company called Juno. But all of them have the same idea. The idea here is that we take the patient's own T cells that did not do the job. We introduce a gene with a virus. We take a virus, some kind of virus that can introduce into the genes of the receptor we want, the anti-CD19 receptor, together with the other parts that will make this T cell effective. And now we have a new T cell with this new CAR receptor, and now we can find the lymphoma cells with their CD19 protein and kill the lymphoma cells. How is it done? The patient gets a procedure that is called leukapheresis. In this procedure, you collect the lymphocytes from the patient blood. You ship them to the factory that produces these CAR T cells, and they transduce it. They put the virus that put these genes, the genes into the DNA of the T cell, and then expand it. And now you get the product, the CAR T cells, the magic bullet, you would call. And in order to give them back, the patient still needs to get some chemotherapy before. This chemotherapy is given for what is called lymph depletion. It means to destroy the other lymphocytes as to give an advantage for the new CAR T cells to attack the lymphoma, and you give the patient these cells back to the patient. So you take the patient's immune system, you educate it by genetic engineering outside the patient body to attack lymphoma cells, and you give it back. So there are two studies that have now long-term follow-up for these CAR T cells in diffuse large B-cell lymphoma. And what you see here is what we call survival curves. So how many patients are alive after a certain number of time. And in this, with this, the first pivotal study of the Yescarta CAR T cell shows that with follow-up of a median follow-up of 3 years, about 50% were alive and without disease. And this compared to something like 10 or 15% with autologous transplant, so much better. And if you look at the responses, about 50% of the patients who got the Yescarta had achieved a complete remission. And those that achieved a complete response, a complete remission, about 90% were alive and well 1 year after the treatment. The Juliet study is the study of the Novartis compound and shows similar results. 50% achieved a complete remission and very good long-term survival for those that achieved a complete remission. So what are the side effects of treatments? We know the side effects of chemotherapy. Chemotherapy sometimes have very severe side effects, but CAR T cells also have toxicities. So treating with the immune system is also not without toxicity, and very specific toxicities that are related to activation of the immune system. And the first one is called cytokine release syndrome. When the T cells attack the lymphoma cells, they produce certain proteins, cytokines. These proteins belong to the activation of the immune system, and they can cause fever, sometimes very high fever, hypotension, and certain other side effects. And this is why this is done in the in-house, in the hospital, and not in the clinic. Patients need monitoring, very good monitoring. Sometimes they can even go to the intensive care unit because of this cytokine release syndrome, but it's most often reversible. Other side effects are neurological toxicities. Patient can get confused and can get certain types of neurological problems, but this too is most often reversible. B-cell aplasia, as meaning we attack with the CAR T cells, we attack all cells that are expressing CD19, including the cancer B cells, but also the normal B cells. The advantage is that the patient can live for a certain time without B cells, but the normal B cells are producing the immunoglobulins that are important to fight certain infections. So patients that had CAR T cells can get loss of the normal B cells, usually for a period of 6 to 12 months. And in this time, they may be susceptible to infections, and they may need giving them immunoglobulins infusions to protect them from infection. And the last toxicity here is called tumor lysis syndrome. We see that with this immune attack, very quick killing of the cancer is destroyed, and the products of this destruction can cause what is called tumor lysis syndrome. Again, needs to be treated by a very strict supportive care during the treatment with the cancer. So these are the commercial available products that we talked about, Yescarta, Kymriah, and the Juno product. They are very similar with certain differences that I will not go into. What we have done in Sheba is that we have produced our own CAR T cell. This is the gene, the vector gene that is used, comes from the NIH, but we produce the product itself by the transfection of the cells with this virus and the production of the T cells in-house. And what is the advantage of that? That it's the procedure is much quicker and also much cheaper when it's done in-house rather than being sent to the facilities that produce CAR T cells. And I would say here that all these new treatments are extremely expensive, and the cost of a treatment with a CAR T cell in the United States may come to $1 million for a patient. So this is extremely expensive. The in-house is much cheaper, but the other advantage is that it is produced very quickly because it's in-house, and from the time we collect the lymphocytes from the patient until we can give him back the CAR T cells is less than 2 weeks, which is very quick, and which allows us to treat patients with very advanced and aggressive tumor that cannot wait for the 5 to 6 weeks that will take to produce the commercial product. So in Sheba, we started this program in 2016, and since then we have treated more than 150 patients, 100 adults and 50 pediatrics. The adults are mostly patients with diffuse large B-cell lymphoma. The kids are mostly patients with acute lymphoblastic leukemia, which is a leukemia of mostly of kids. And overall, of these 150 patients, about 60% responded, and about 40% achieved a complete response, CR. And if we look at the survival curve, about a follow-up of 3 years, about 40% are alive and well. And this is very similar to what I showed you in the large studies of the now commercial products. This is amazing because when you do a clinical study, the patients that go into the clinical study are usually patients with better performance status, less aggressive malignancies. And here we treat all comers, including patients that will never make it to a clinical study. And the results are very similar, meaning that this treatment is very effective. Just to show you one example, a patient, all these black things here are tumor of the immune system. Here on the yellow is the PET scan that show the uptake of glucose here, and within few weeks of treatment, all is gone, almost all. This is amazing to see. You see the tumor go away in really quickly with the fight of the immune system. So I talked about diffuse large B-cell lymphoma, which is the most common lymphoma, but there are other lymphomas also. One of them is called mantle cell lymphoma, and here recently approved another type of CAR T cell that is, again, the name is unpronounceable, but this is very similar to the Yescarta and has amazing outcomes in this rare type of lymphoma, mantle cell lymphoma, that is in settings that are otherwise untreated. The other disease that is also susceptible to CAR T cell is acute lymphoblastic leukemia. And this is mostly in children. And the product, the Novartis product, has been tested and in children with recurrent leukemia, and is also approved for young adults up to the age of 25, because these are the patients that went into the study. But we have treated also adults with our own product with this type of leukemia, and achieve results that are similar to the results of allogeneic transplantation, meaning transplant of bone marrow from a donor, and sometimes even replacing this treatment or treating patients that have failed prior transplantation. And the other disease, which I will not have time to cover, is multiple myeloma, a very common cancer of the bone marrow that is now getting into the CAR T cell field. Here, the product is different. It's not directed against CD19, but against other proteins that are expressed on myeloma cells. And in the very near future, it's going to be, we expect it to get approval and be part of the schema of treatment of this cancer of the bone marrow, multiple myeloma. So, but autologous CAR T cells still have some limitations. First, the treatment, the therapy requires that each product is specific for the patient. It's a patient-specific product. You collect it from the patient, you send it to the facility that produces the CAR T cells, and you get it back. And because of this, it's a patient-specific product. The manufacturing is complex and expensive, and it takes several weeks, sometimes 2 months, to get the product back. And for patients with very aggressive lymphoma, this is too long. They cannot wait so long. Also, patients with rapidly progressive disease, they have their own T cells are sometimes dysfunctional from treatments, from prior therapies. So even if you are able to collect enough T cells, sometimes you're not able to produce a good enough autologous CAR T cells. And some patients still do not respond. We already talked about the toxicity profile. How can we improve this treatment? So we have new CARs. New CARs have modern things engineered into them. For example, you can produce a CAR against 2 proteins, not just against CD19, but against CD19 and CD20, or CD19 and CD22. So when you have 2 targets, then the chance of the cancer to avoid this bullet is reduced. And we look at combining the CAR T cells with other agents, immune therapies that increase the activity of the CAR T cells, like what is called checkpoint blockades and immunomodulatory agents. And the future is in the production of universal cars, meaning cars that are not from the patient, but from a third party, that are already produced off the shelf. You can buy it and give it to the patient, and this will make things much easier. And there are now companies that are starting to produce this type of CAR T cells. So CAR T cells have, just to summarize, have revolutionized the field of cell therapy and changed the paradigm of therapy of many patients with relapsed or refractory B-cell malignancy. But despite this progress, there are still limitations to this scheme of therapy, and we are looking for the future for better and novel immune therapies. And I will conclude here, and thank you for your attention.
Thanks, Avichai. Thank you so much. If you do have questions for Avichai, please put them in the Q&A section, either on Zoom or alternatively on YouTube, and we'll move them across. But Prof, can I ask, it looks like we've made major progress with messenger RNA vaccines for COVID, but the initial research on messenger RNA was in fact about cancer treatment as well. Do you think we're going to, between getting the human body to either change its DNA or alternatively use our own T cells, do you think between those two therapies we will cure cancer within our lifetimes?
Oh, there are certain types of cancer that are already curable. For this diffuse large B-cell lymphoma is a curable disease. The CAR T cell is for those that are not cured with modern chemotherapy, but in the future may be treated with upfront therapy. Messenger RNA does not change the genome of the patient or the cancer cell, but can get immunity. Can produce the immunity in-house, in the body. The CAR T cell is giving the effector cells, those that will attack the tumor. It's not the engineering of the immune cell is done outside the body. There are now CAR T cells are mostly for lymphomas, but they are starting to get into solid cancer also. And there are other types of immune therapy. Some are patient-specific, some are gene-specific, some are tumor-specific. In the future, in 10 years, we'll treat probably many cancers without chemotherapy, but just with activation of the patient's immune system or given effector cells that will kill the tumor.
I see there's a question that says, will Keytruda cure lots of different cancers?
Yes, so Keytruda is what I said is something that activates the T cells in the patient's body, and because there is a fight between the patient and the immune system and the cancer cells, and the cancer cells sometimes give signals to the immune system to tolerate the cancer rather than to kill it. And Keytruda breaks this signal. It tells the immune system, kill these tumor cells, don't be energized, don't be tolerized against it. So Keytruda and the other types of these treatments activate the immune system against many cancers, including solid cancers, not only in hematology, but also in hematology, it's in lymphoma and other cancers. So yes, it's one of the new treatments.
So Prof, the last question that we have time for comes is, can CAR T cells be used for non-Hodgkin's?
Yes, diffuse large B-cell lymphoma is a non-Hodgkin lymphoma. The lymphomas are divided into Hodgkin and non-Hodgkin. It is currently for the non-Hodgkin part. The Hodgkin part, there are certain CAR T cells also for that, but only at the beginning. The non-Hodgkin is the type of lymphoma that express this antigen, this protein CD19, that is susceptible to the current CAR T cells.
Great. Professor, thank you so much for joining us this evening. I'm so sorry we've run out of time. Really appreciate it. If you could unshare your screen and thank you so much. If you do have any questions for the professor, please put them into the Q&A section, and I'm sure he will actually answer the questions in the exact same way that that we've been doing with Michal Beeri, Professor Michal Beeri, who's been answering in the chat section as well. And with that, Professor Eli Schwartz, good evening. Thank you so much for joining us.
Good evening to you.
It was a late call up. I was watching a webinar yesterday or the day before, and that was with Dr. Paul Marek, who's an ex-South African professor in the United States, a big proponent of ivermectin. And ivermectin as an issue has exploded in South Africa with an entire lobby, particularly from the medical fraternity, trying to get our drug a regulatory authority to approve ivermectin as a treatment, and them saying, well, there's not enough data, there's not enough information to actually pass comment either way, but they will allow it on compassionate grounds, whatever that means. But Professor Marek made reference to an Israeli study. So I went onto the web last night to try to find the Israeli study, only to find out it was done at Sheba, it was done by you, but there was no information since June of 2020. There's been no published data. There's been no peer-reviewed data. There's been nothing. And at that point in time, I called Yair last night and said, is there any way someone from Sheba can tell us about the study and give us some information, even if it's not peer-reviewed, but at least to understand whether, in fact, we're barking up the wrong tree with ivermectin or whether it's hope. So thank you at the very last moment for agreeing to come do to us. And tell us, is there good news? Is there bad news? Or should we go wait another 6 months for our vaccines in South Africa?
I must say that also for me, surprisingly, I'm going to share with you good news. And you are the first in the world to hear the results. So it's not peer reviewed. Even the Israeli, my colleagues, still did not listen to it. So you, as I mentioned, you are going to be the first to see it's still preliminary. We have to finalize it, but I think the direction is quite clear-cut.
So, Prof, just before we do, there's been some very small ivermectin studies coming out of Bangladesh, some coming out of Egypt. There hasn't really been a first world study. Yours is really the principal first world study with first world scientists busy looking at it, which is why it has so much significance for many of the regulatory authorities.
I agree, and I think this is one of the main drawbacks, that people in the West don't accept so far the results which came from these, what we call third world countries, low resources countries, because they are, first it came from these places that you are not sure about the science there, and also many times it's not well done. I mean, not every time they have placebo arm, not every time they have a good way to make a diagnosis. So therefore, people are looking for really results from main medical centers.
So now your research that you did was double-blinded. Patients were given a placebo or non-placebo. There haven't been any other real studies relating to like that.
Yeah, I think it's the first one. My feeling is it's really the first one to do in the proper way, and I'm going to show you.
Please, the floor is yours.
So do you see it?
Yes, we do.
Okay, so I mean, the ivermectin story, it's really become a project, and we have few other items that I'm not going to discuss it this evening. But before starting, I just want to highlight that the ivermectin is really an excellent drug, and it's changing many aspects of the world, working against infection causing by certain parasites. Now, again, in many Western countries, they are not familiar with the drug. It's not registered in many countries, including Israel, and therefore I think part of the hesitations of doctors around the world is because they are not familiar with this drug. And as you can see, there are not many drugs who won the Nobel Prize along the years. And one of them, it was the Ivermectin, which got the Nobel Prize of Medicine in 2015. So it was not given for antiviral activities, but rather anti-parasitic. But when the story of when the corona pandemic started, in vitro studies, which actually the first was done in Australia, showed high activity against the coronavirus, and that's triggered more work and clinical work to see whether it's really work among patients, not only in vitro studies. So our study was ivermectin versus placebo. And again, we looked at the mild cases, non-hospitalized patient, and it was double-blind randomized control trial. And later on, I will tell more about the looking into this type of patient, because people may ask, well, why we have to bother ourselves with patients who are already diagnosed as having mild disease. So just to go quickly, it got the IRB, the Helsinki approval by the Sheba Institute, by the Minister of Health, and it's also registered in the NIH in the clinical trial gov, and you can see here the number. The objectives of our study was reduction of viral shedding among mild to moderate COVID patients. So it's usually the beginning of the disease where they are not severe, not hospitalized, good oxygenation, and to see whether in these people we can shorten the viral shedding. The other part was to evaluate the effect of ivermectin in preventing progression of this mild disease to a severe disease. I can tell you now that the sample size, and I mean, all this was decided at the beginning of the outbreak. I'm talking about March of 2020. So many aspects we learned later on, and also that only small fraction of the people are progressing into severe disease, and therefore we cannot answer the second question. So the study design was to go to community, and in Israel we have dedicated hotels that people who cannot be, people diagnosed with corona and cannot stay at home, they are moving to hotels. And we thought that because they are concentrated together, from the manpower point of view, it would be much easier to reach them in the hotel instead of running one by one to different houses around Israel. And we took all adult people above 18 years old, and pregnant women were excluded. Now, because we were looking for viral shedding, people with asymptomatic disease also were included, because we will follow them, as you will see, by nasal swab to see whether the virus disappeared or not. So the intervention was either giving ivermectin, and we have to remember that ivermectin is given according to body weight, or to give them a placebo. We decided to go more or less to the usual dose. Dose per day is usually 0.2 mg per kg. And usually for parasitic disease, we give it for 1 day. We decided here to increase the dose and to give it for 3 days. And therefore we split the group to people up less than 70 kilo and people more than 70 kilo, and they got 12 milligram to 15 milligram again for 3 days. It was double blind, and the placebo was done in the same, it looked the same as the ivermectin. So it was really completely blinded for all sides. Now the follow-up was to go and to do every 2 days, to do nasal swab, and actually to follow and to see who is going to be negative earlier, the placebo or ivermectin, or maybe there is no any difference. The primary endpoint was to see what's going on at day 6 from the intervention. The sample size that we found was about 50 patients per each arm, so it's altogether about 100 patients, and this we were looking for 25 decrease in the timing of between the two groups until coming negative. Actually, what's happened that final recruitment was even more, 116, but because we have quite high of dropout, you see 22 had to be dropped out usually because they came to the hotel at the end of the disease, so we're almost negative or negative, and we could not look after them. And therefore, at the final numbers, we got ivermectin 49 and placebo 45. So just to show you, when we looked at the patient characteristic, we see that there's a small difference in the numbers we mentioned between ivermectin group and placebo, but all other parameters, the age, the number of risk factors, gender, weight, and weight is important because, again, this drug is given by weight. The percentage of asymptomatic patients, or the recruitment altogether, the recruitment CT level. CT level means, I'm not sure again how many people are familiar with the term here, but it means the number of cycles that you have to do until you find the virus. And if you have high cycle, that means you have a very low viral load. So we see that, you don't see it here, but the level of CT level at the recruitment was quite similar in the same in both groups. We try to get them as soon as possible after the initial symptom. However, especially at the beginning of the pandemic in Israel, it took time until patients decided to go and to be checked. It took time until they got the results. So finally, we managed to get them around the median time 4 days from the beginning of symptoms. Now let's go to the results. If you see, these are the mean CT level every 2 days that we follow them. Just to remind you again that when you have high CT level, it's good. It's mean the patient is going to be negative quite soon. So you can see what I dropped here is, this is the beginning symptom onset. We have about 4 days until they were enrolled. And then we started to see, they started almost the same point, and we see that with the ivermectin, they become high CT level, again, means low viral load, much more quickly. And here, this is the placebo arm. But you see that around the 10 days from symptom onset, they are becoming quite equal. And that's make it also more complicated, the follow-up of all this type of trial. If you know, or if you're familiar, in most countries of the world, the policy today is that after 10 days from symptom onset, you can be out of isolation. And why? What's the point? The point is that usually after 10 days, even without any treatment, you become negative, or to say it more precisely, you are non-infectious. So you see here, people are in CT level above 30, which considered to be non-infectious. So just to show you that if you need to find advantage, it should be at the early stage of the disease. So if we go and see now, what's the percentage of people who become negative or non-infectious at day 4, 6, 8, and 10, you can see that in the ivermectin, on day 4, 57% become negative compared to only 31 in the placebo group. And because the numbers are smaller, the sample size here, the p-value is almost significant. However, from day 6, which actually was the primary outcome, we see that it's highly significant that more people in the ivermectin group become negative, much more than the placebo group. And it continues to day 8 and 10, and later on it will diminish, as we mentioned, because even the placebo without any treatment, they become healthy. So this one way to show that ivermectin really has an impact on the viral shedding. In multivariable logistic regression model, we can see that taking into account the gender, the age, weight, and whether patients have had symptoms or not, we see that ivermectin, the odds ratio of ivermectin to get the patient negatively at day 6, it's more than 3 times compared to placebo. So it's really highly significant that with the ivermectin, you can reduce the viral load and patient become much more quickly become negative or less non-infectious. And this is the Kaplan-Meier way, Kaplan-Meier analysis. And this was done in symptomatic patients that we know exactly when the disease started. So you see the difference. The blue line is the ivermectin, which become negative quickly compared to the red lines, which are the placebo. So all this showed us that there was a really positive impact to the ivermectin. So all these aspects are related to viral shedding, which I mentioned to you at the beginning. This was the main primary endpoint. Looking into the clinical deterioration of the patient, we understood during the study that we are not having a sample, big sample enough to show it, but just to show you that among these people, we have about 10% who were more than 60 years old, and you see about 20% has another risk factor beside the age. And you can see that in the ivermectin, none of them deteriorating and required hospitalization, while 2 patients in the placebo group required hospitalization. So this is very small sample, but it means that we have to look further to this group and to see whether we are going to have another advantage of the ivermectin by preventing the deterioration, preventing hospitalization, which we know that this is one of the main problems with the COVID pandemic, that hospitals are flooded with severe patients. So other point is just about the safety issue. I'm running the Tropical Institute in our hospital, or actually is the only one in Israel, and we used it a lot before the corona, and we know that it's a safe drug. But just to emphasize that also here, that we had no any safety issue with the patients. And again, the total dose that we use is slightly higher than was used in the daily antiparasitic infection usage. So in conclusion, I can say that ivermectin, with our study, ivermectin demonstrated that it has anti-SARS-CoV-2 activity, which is highly important, and people are not sure about it. We have to remember that in the literature, they are mentioning that ivermectin may have antiviral activity and may have also anti-inflammatory activity. Since we are talking about the beginning of the disease, the effect must be as an antiviral. Anti-inflammation relates to the second stage of the disease when people got the cytokine storm. So here we are more focusing about its antiviral activity, and we actually showed that it reduced the viral shedding period, and therefore it reduced the infectivity time of the patient. And this has a significant public health impact. And I told you at the beginning, people ask me, why do you interest in having mild patients with slightly less days of being infection? We have to remember that 90 to 95% of the COVID patients are here in this category. And the economic burden, the social burden, all related to the isolation and to prevent them from being either at homes or being at work. And if this is really work, it means that instead of being isolated for 10 days or 14 days in other countries, maybe at the beginning, at diagnosis, they can have 3 days of treatment, and afterwards they can be outside of the isolation. So it's a major change in the economic of this pandemic. So we have to remember that from this aspect, this is highly important, especially for countries which are the most countries in the world which still don't have the vaccine. Vaccine is not available. Only in Israel, we really running with the vaccine, and actually still we don't see the reduction in number of patients. So or let's say it even more, the thought that the vaccine going to solve the whole issue, it's kind of a dream. It's going to take a long time until mass majority of the population will be vaccinated. We know the children are not being to be vaccinated for many years, and we know that many people still don't want the vaccine, or it's not available. So the need for a drug which can really shorten the viral load, shorten the infectivity time, it's highly, highly needed. But if I ask myself, or if you ask what the other implication, if we know now that it really has an impact on the viral load, then we can use it for two other purposes. One is the second one, prevent clinical deterioration, which I mentioned before. If people at the beginning, and especially we have to target, let's go and talk only about high-risk people, those who are at age more than 50 or 60 with another risk factor, and to this relatively small fraction of the population, give this treatment to avoid the clinical deterioration and the need for hospitalization and ventilation, etc., etc. And the other way to use it, it's if it goes and it's antiviral, so maybe we can use it as prophylaxis. It means if you have an index case at home, then immediately after diagnosis, give ivermectin to the whole household people, and then maybe you can prevent the infection of the rest, or you can do it for healthcare workers who are exposed themselves quite often. So all these type of things are now, I would say, are possible. It should be done, or we should continue and do more studies relating to these aspects. We thought about doing a study in Israel about clinical deterioration. However, with the vast majority of people over 60 being vaccinated, we thought that we are not going to get enough people for this study. So just this week also, there was a study you mentioned about the Egyptian study. So here's a study from Egypt, and you see that they try to look for it as a prophylaxis drug. So you can see that people who got the ivermectin, this is the blue, only 7.4 out of 203 person become sick, while more than 58% among those who did not get ivermectin became sick. We have to remember that 2 points. One, there was no placebo. It was intervention without intervention. And the second, the diagnosis, for example, was based on clinical outcome and not on PCR, because the limited resources they have in Egypt. So again, it's very nice, but many people in the West may hesitate to take it as a strong evidence. Now, few sentences before we conclude about ivermectin around the world. So what's happened in the world is really interesting. In some places, they use it quite often. However, in the Western countries, many places they don't want to use it. And here, for example, I just got this week that a judge in New York orders a hospital to use ivermectin, because the general practice is we don't have any good proof for it. We don't want to use it. If you go to the endemic countries, for example, here you see in Peru that they use it quite a lot, like a water, and they are sure that it saved many lives in this area. Or here, for example, this is so a part of it is in Hebrew, but so people who can read Spanish, they're mentioning about evangelist group in Peru who decided to inject the veterinarian ivermectin. Only the veterinarian has it as an injectable form. And they are sure that they saved the life of this village by getting the veterinarian ivermectin. Here you can see in Bolivia, one of the major cities of Bolivia, that they decided to combat the disease by giving mass drug administration of ivermectin. And here you see I got many emails, and you see that one guy who mentioned in September that physicians are skeptical about taking ivermectin since no official placebo control has been done, and we need more info. So could you reassure me somehow that you are seeing positive results? The world is looking forward to your study. So that was in September, and I could not reassure him because I didn't have the results. As I told you, I got the results only this week. But I can say that the Western attitude is very strange. For example, the NIH stated firmly a few months ago that he is against the use of ivermectin. Only a few weeks ago, they changed a bit the statement, and they say we are not pro and we are not against it. So now everybody so-called can decide. However, the interesting point, for example, is Merck, the company who actually, they are the original one who manufactured the drug, the ivermectin. And they came out last week with a very strong statement saying that don't use it for COVID-19. And they also has concern about the safety of the drug. This is very interesting. I mean, it was given as a mass drug administration, I think, for millions of people, and no any safety concerns. So if you change the purpose of giving it, it does not change the safety of the drug. So people start to say that maybe there's something else, not only science behind this, and maybe because Merck is working on 2 new drugs against COVID, maybe they don't want a competition from an old drug, cheap drug without any patent. So see, not everything is only science, it can be kind of politics and business. And just to show you, maybe I think is the last slide, this is from the New England Journal of Medicine from this week also. And there's a news paper in this journal saying that the WHO declared that all the common drugs that people try to use for COVID, remdesivir, hydroxychloroquine, lopinavir, and interferon, all these are useless and don't use it. And despite this strong statement, people still, many hospitals still use it. Ivermectin, which there are many studies, not high quality studies, but showing the advantage of it, we don't have really something which showed us differently. And despite it, there is a kind of an anti-usage of ivermectin. Maybe I'm afraid because of the farsa which happened with the hydroxychloroquine, which was, wide use of it without any good science behind it. Maybe that's create the anti-ivermectin movement in many Western countries. Thank you.
So Eli, if I could ask you to unshare your screen, there's so many questions coming in. Let's talk about what you can't talk about. So I presume you can't talk about the effectiveness of ivermectin and the dosage regime, other than to say that you tried a specific regime and these are the results of a specific regime. Is that correct?
Just a minute. I try to close it, but
should be unshare screen.
Resume.
Otherwise, I can probably.
You can try. Here. Okay.
Okay.
Yeah. Okay.
Here we are.
Please again.
So let us say a number of people are asking about what is the correct dosage for ivermectin, but you can only give us the results on your study on the dosage that you used.
Yeah, I can say that there is a group, international group, collaborating with Andrew Hill, Dr. Andrew Hill from Liverpool, who try to make meta-analysis. One part of this meta-analysis showing that if you give a higher dose of ivermectin, you get a better result. So I would say that it moves from 1 day of treatment to 5 days. We are in the middle. So again, I can say that our study showed clearly that ivermectin works against the virus. Is it the best dose that we have been using? I'm not sure. If we have time and if we have kind of background and helping us to do more studies, or if you want to do in South Africa, I think we can try to look for different dosing and see whether you get better results.
So when will you be publishing your results? So people, even if it's not peer reviewed, when will people have access to the data that you've shown us this evening?
It will take, I would say, at least a couple of weeks.
Okay, we have had a lot of questions about what are your thoughts on ivermectin as prophylactic. In your mind, do you think the Argentinian results have in fact proven its effectiveness?
Again, I want to emphasize, and I get this question from different views or different thoughts. One thing is, let's assume you have a person next to you at your house who got sick and you want to prevent the disease in yourself. Should I take ivermectin? I would say go and take it. There's no any disadvantage. I don't think we have still very good solid data, but since we have good data that it's antiviral, go and take it. What I'm saying is that many people, I got, especially in Israel, that the vaccine is available, and there's many people with the anti-vaccine opinion, and they try to get for me ivermectin instead of vaccination. And this is, I think, is useless. I mean, you can't take ivermectin until the pandemic will be over. So again, for incidental exposure to the disease, go and take it. For instead of vaccine, it's not going to be replacement.
Okay, I see a lot of people here asking questions about ivermectin and children. How young were the youngest people in your studies?
We dealt only with adult, means more than 18 years old. However, we give it, you can give it in many countries. You give it for lice, for scabies, for all these type of things. So it's not contraindicated in children. And as the child can swallow tablets, you can give it to him.
Then there's a question from Estelle to say, is ivermectin already being used in hospitals in Israel?
No. Again, I mean, most of the physicians even didn't hear about the drug.
Okay, and someone is asking about the shelf life of ivermectin, but once again, I think the important thing is to get a product that's not expired. People are asking about veterinary ivermectin. I think that's very much a South African thing. Consult your doctor. Professor Schwartz can give you the details of his study, but really consult your own doctor, please. That I think is the most important thing that we can at this point in time. So Eli, probably the last question that we're going to take on ivermectin is obviously Professor Marek and Professor Corey in the United States have been leading the charge for ivermectin internationally. Have they seen the preliminary results from you yet? They haven't. We are the first. Okay.
You are the first.
So we are world breaking news tonight that obviously we should get in touch with them and ask them to watch this video of this evening. Is there any other advice you've given us? Clearly reduces viral load in those people already with the disease. People who are hospitalized probably have some degree of advantage to taking it. If you've been exposed, probably a fairly good idea to take it prophylactically at that point in time, whether you've received it or not. There's no results on mortality rates or anything with or without, because I presume no one in the study actually passed away.
No. Actually, again, by this meta-analysis, which I mentioned to you, there are many studies looking to the survival, and it showed clearly a better survival with ivermectin compared to placebo, to non-intervention.
Okay. There is a question from Linda Crawford about side effects. Are there any serious side effects?
No, as I told you, the safety was excellent. Among these almost 120 patients who used it, we didn't have any complaint which could be related to the drug.
Okay. People are asking once again about doses, how much they should take. Once again, please consult your own doctor. All Professor Schwartz can do is tell you what he has used himself. Or did we just lose Professor Schwartz? I think he's just disappeared, but I'm sure he'll join us again. But please speak to your own doctor about it. This becomes very much a discussion and a choice between you and your own doctor for these things. But thank you to Professor Schwartz for joining us this evening. This is literally world-breaking news, and so we really appreciate it. I think Professor Schwartz is back with us. Just connecting his audio and video again. Eli, are you with us?
Yeah, now I'm. Yeah, I mean something happened to my computer, so now I'm with my mobile phone.
There's a question from Ruth about Allocetra, a drug very effective in treating COVID patients. I don't know if you have any knowledge about that at all.
No, any experience with it. And so far, I don't think there's any good drug that really was proven. I mean, steroids seems to do something. Actually, probably less than ivermectin. If you look for the percentage of changing in the clinical outcome.
Okay, I see Colleen saying, is there not disinformation about side effects? Does it not cause blindness or death?
No.
Okay, so Professor, thank you for joining us this evening. This has been unbelievably valuable. I think there have been so many people in South Africa who've been waiting for a sign of some good news. And for those of us, we imported the AstraZeneca vaccine into South Africa only to discover that it's only 22% effective against the South African variant of COVID. So we're now swapping it out for Johnson & Johnson, and we're desperately trying to get hold of any vaccines here because unlike Israel, we haven't yet vaccinated a single person in South Africa other than as a trial. So we've got a lot of catching up to do. But thank you for joining us this evening. Thank you for giving us good news. Thank you for giving us breaking news. And we really appreciate the fact that you joined us.
Thank you so much. Bye-bye.
Erev Tov, Shalom. Nomi Hadar, turn on your camera. And I'm going to ask the same to Yair as well. Maybe Yair, you can also turn on your camera. I mean, tonight we are seeing some astounding information of world-leading science taking place over here. Nomi, you run the South African Friends of the Sheba Medical Center. Tell us the sort of work that you've been doing.
First, I want to thank you for giving you and the Jewish people for giving us this special opportunity to expose our expertise from Sheba and to show you what we are doing. And I'm so stunned by we've been the first one to hear about this breaking news. And I think that I saw some people even today that holding this in case they will need it. And I think it gives them a lot of encouragement. I want to tell you a little bit that I'm so proud to represent the Sheba Medical Center as the executive director of the African Friends of Sheba. And I'm proud to be present the biggest medical center in the Middle East and one of the 10 best hospitals in the world. And we believe that the sky is not the limit. What we are doing here is we're trying to cultivate the cooperation between South Africa Hospital and the healthcare system and Sheba, South African academic, and the other communities.
Ooh, Nomi, I think you've got a problem with your connection over there. I think we've lost Nomi. Yair, are you with us?
Yes, I'm with you.
Okay, while Naomi tries to get her internet.
I saw Eli.
Sorry, your internet connection seems a little unstable at the moment. We can't really hear you. But Yair, while we try to sort that out, the relationship between South Africa and Sheba goes back a long way. There have been many South African patients who've come to visit you at Sheba, and there've even been times where you've sent out medical staff to South Africa to look after patients that are in your care who are here.
Absolutely, we are definitely doing that. We are doing that not only to South Africa, but other African countries. We've been doing it in Malawi a couple of months ago. A group of our experts went to Malawi to look out for some help that we could have might have been giving them on oncology matters. We've been in Ghana, we've been in Zambia about a year, or just before Corona started. So yes, we have a very, very long relationship with South Africa and with other African countries. And either humanitarian or any assistance that we could give.
Naomi, let's see if your internet has stabilized, if we can hear you again.
Can you hear me now?
Okay, that's a little better.
Okay. I don't know what part of my word did you hear, but first I want to thank you again for this amazing opportunity. And one of the things that already you heard that what we're doing a lot of collaboration between hospital in South Africa and Sheba. We're doing collaboration between doctors, between other health workers, and we're helping people in South Africa to get second opinion in Sheba, or in some time just to get a special treatment that one can get in South Africa. And you already told everyone about late Kulani and Lehavdil, about Dr. Tessie Reddy that got an unbelievable help from Sheba. And
so Naomi, before we continue that, we want to give people the opportunity to, in fact, make a donation to Sheba. So Danny, I'm going to ask for two things. Danny, if you could pull up a poll on Zoom to allow people the opportunity, if they'd like to make a financial contribution to the amazing research and assistance that Sheba is giving to the people in Israel, to the people of Africa, to the people in South Africa. We've put up, please feel free to make a donation on the poll. We'll contact you should you wish to make a donation. If you're watching on YouTube, what we've done as well, you will see on YouTube that there is a link that Danny is going to post in the chat as well. It is a link to a Google spreadsheet, and you can just put in your information there and we'll contact you to allow you to be able to make a donation to Sheba as well and support the amazing work that we're doing. But Naomi, while they do that, I just want to tell people, or for you to tell people, about a fundraising event that you had not so long ago. And at that event, you invited the ambassador from the United Arab Emirates to South Africa. And tell us what he pledged. The first time ever that an Arab government official has pledged money to an Israeli institution.
Yeah, I must tell you that it was an unbelievable occasion. I decided suddenly, because I knew in this special event, we have some collaboration with the Emirates, and I decided to invite the ambassador, and I thought maximum we can say no, but was very happy. And then while we have our event, he called me and said, I want to announce something. And I said, I would like to contribute. And I've said, that's great, I couldn't believe it. And then he told me that he's giving 2 million rand to Sheba. And that was really the first time ever in the world that the Emirates had any participate in any Jewish Israeli event and contribute such significant amount. And what he said to me, Naomi, it's only the beginning.
Fantastic. That's amazing. Thank you to everyone who has contributed this evening. We really, really appreciate it. At the end of tonight's program, we'll put that up again and just allow people the opportunity, if you haven't yet made a donation, to make a donation. We're running a little short of time, but we did want to give one other person the opportunity to speak tonight, and that's Ohad Benjamini. So Ohad, if I can ask you to turn on your camera. Yair and Naomi, thank you so much for joining us. Sorry to have kept you so late. Ohad, our apologies.
It was very interesting to hear all the talks until now, and it's my honor to your invitation.
So once again, you're a cancer specialist. You're doing some amazing stuff in looking at novel therapies in the treatment of cancer. Can you tell us a little more about that?
Yes, so actually, I would like to talk to you a more general overview of our approach to cure an incurable disease called chronic lymphocytic leukemia, which made a breakthrough in the recent years. And I think it's very interesting and some triggering.
Great, fantastic. The floor is yours. Please go ahead.
Okay. So as I said, I'm going to speak about the progress we have made with chronic lymphocytic leukemia. And it will be a more general talk than Professor Shimoni made on cancer. And something is, what is fascinating in bowhead whales, so they are big, but they are not the biggest whales. But they are longest living mammals. Actually, they live up to 200 years. And why is it? They have one of the reasons that they have a very good repair mechanism due to cancer-resistant genes. So, and what is the most frequently mutated gene in human cancer? This is a gene that produces a protein called p53, and it's called the guardian of the genome. How it guards the genome? Actually, cancer cells produce mutations, and this gene this protein works to initially repair the mutation happened in the DNA, and then if it can't repair the DNA, then it moves the cells to arrest, to cycle arrest, and if not, if impossible, it activates a self-destruction process called apoptosis. So that this gene is important in cancer, producing a protein which is activated DNA damage to eliminate these cells. And mutations in this gene is actually an Achilles heel because it impairs one of the important processes that our body fight cancer. I'm going to speak up now how it's important in the disease that I'm very interested in, which is chronic lymphocytic leukemia. This is an indolent malignancy, hematological malignancy with natural history of many years. There is a gradual accumulation of neoplastic B lymphocytes in the blood, in the bone marrow, and lymph nodes and the spleen. And it is the most common leukemia in the Western world. The incidence about 4 to 5 cases per 100,000. In Israel, we have about 400 cases per year. In the US, 20,000. This is many patients live long with the disease, so the prevalence is high. It's about 180,000 in the US. So what is the clinical course for a typical CLL patient? Initially, there are no symptoms at all for a prolonged period of time. Patients are diagnosed often incidentally. They do a blood test and the white count is high. And then gradually, there is increase in lymph node size, in the size of the spleen, and they're starting with time bone marrow impairment. The hemoglobin drops, the platelet drops, they have fatigue and bleeding tendency. And the hallmark of CLL patients in the advanced disease is their impairing the immune system and susceptibility to infections. This happens within years. But the disease is very heterogeneous in its clinical course. On one hand, there are many patients which live similar to age match healthy individuals, actually about 30% of patients. On the other hand, there are about 10% of patients with aggressive disease, with life expectancy of less than 3 years. The highest risk in these patients are those patients with this TP53 gene mutation. So an overview of the treatment of CLL is from the 60s, started using chemotherapy, initially with only a partial response, decreasing the lymph node size, but gradually improving with more intensive chemotherapy. And then to combination of more on that, as opposed to chemotherapy, which is not specific and just destroying the DNA of the cells and causing a lot of self-harm, introducing antibodies made it more specific and even prolonged life. The problem with this combination of chemotherapy, chemoimmunotherapies, it is its toxicity. The disease is a disease mainly of elderly, and it causes bone marrow suppression and increased infection. And in addition, it is not effective with high-risk genetic features as the TP53. In the recent years, we introduced the novel agent, the targeted therapy, and they are effective in high-risk genetic features, including this TP53 mutation. So there were two breakthroughs in the recent years. One in 2014, and the second in 2016, introducing the targeted therapies. So what are the targeted therapy? These are small molecules which are selective to specific processes in the cells, which are very crucial to survival of these cells. One focusing on signals then coming from the surface of the cells, the B-cell receptors, and causing some processes in the nucleus of the cell to affect the cell proliferation, survival, and death, which are hallmark of cancer cells. And the other is like pushing the cells over the cliff, activating programmed cell death in the cells, a process called apoptosis. All the cells in the body has like a biological clock. Cancer cells evade the immune system by preventing this process of apoptosis. And BCL2 inhibitors are molecules that activate the apoptosis to kill cells. This is an example of a patient. This is a 54 years old gentleman with high-risk CLL. He had a TP53 mutation, and he was resistant to chemotherapy. And he started on a BTK inhibitor, and very remarkable improvement, shrinkage of the lymph node. This is a pill, very safe with not so much toxicity as with chemotherapy. His count improved, his hemoglobin improved, and the symptom improved. And you can see the changes and the shrinkage of the lymph node very remarkable. So what we achieve with these novel therapies, the much less toxic therapy. It is tolerable in this population of the CLL patients, which are elderly, and also patients with comorbidities, other disease can take these therapies. It is effective in high-risk genetic features and as TP53 mutation. It is easy to take. Patients are not coming to the hospital. They are taking it, which is in these Corona days very important. The BCL2 inhibitors are time-limited therapies. They produce very deep responses until undetectable cells and prolong life towards cure, actually. It is impossible not to speak about COVID in this talk. So now in Israel, trying to give everyone like a green passport to be free. And what is more serious than CLL patient not vaccinated to COVID, it's actually CLL patient vaccinated not knowing that he has no immunity to the virus. I want to give you some examples and reasons. Because
sorry,
of this patient.
Ohad, yes. Someone just contacted me. Should we be seeing your slides?
I'm sorry?
Should we be seeing slides as you go through this? Because we haven't been seeing any slides.
Oh, this is. Okay, I'm sorry. So. Can you help me sharing?
If you click the share button at the bottom of the screen, there's a green button that says share screen.
Okay.
Okay, there we go.
Okay, so
I think continue from where you were.
Yeah.
So just flip through to where you were.
Yeah, so I'll move more forward. Without the picture, probably it was very difficult to understand what I'm talking about, but I hope you were alert. So these are about the therapies and their process. And this is the person that I spoke about and the response to the treatment. And now hint about what happens with CLL patients and COVID. So this patient has suboptimal immune response to vaccination. Actually, the case fatality rate in symptomatic COVID CLL patients is up to 30%. And only 67% of CLL patients produce antibodies after infection compared to about 98% of the population. We have information about the antibody response to vaccination in CLL patients. For example, in hepatitis B, only about 28% of patients produced antibodies, and patients treated with BTK inhibitors, only 3.8%. It's very different with different vaccines. For example, in varicella vaccine, it's up to 60%. Influenza vaccines, patients treated with these BTK inhibitors is only up to a quarter of the patients. At Sheba, because in Israel we are rapidly vaccinating patients, at Sheba Medical Center, we started collecting serology and the antibodies, the serology is a response to the vaccine after a couple of weeks after the second vaccination. And the sample we had for now only 40% seroconversion to the virus in this patient, and we actually excluded for now. Patients received recently therapies which eliminate B cells that produce antibodies. So this is quite favorable group of CLL patients, and even those have only 40% seroconversion. So what we need to know and think about CLL patients and patients with impaired immune response, initially, we need to take into account the vaccine factors. We are now dealing with our mRNA vaccines, but patients' age and comorbidity has effect on the efficacy of the vaccine. The hypogammaglobulinemia, the low antibody levels of these patients, which is inherent in this disease, it's very important, and many patients has about 70% has low immunoglobulin levels, and the types of previous therapy that the patients received. There are specific therapies we know that they are very very harmful to the B cells, to the cells produced, to the immune cells, to the cells producing antibodies. And patients in CLL patients with recurrent infections receiving immunoglobulins, but those for now are not effective in, against COVID because we don't have enough resources for IVIG with anti-COVID antibodies. So after patients are vaccinated, we need to check how many patients mounting the immune response, and this is what I just showed you. But it is very important to know for how long this immune response persists. At Sheba, actually, all personnel that are free to take part in trials that check every month the amount of the antibody, and we see from healthy people that there is a reduction in the antibody titers. In the CLL patient, we saw that the titers are low, already low at the beginning, so we need to think about what is the persistence of the antibodies, the reduction in the incidence of infection, and for how long these vaccines will be effective. And maybe some patients will need boosters, and many other questions. Another issue that is related maybe to the CLL treatment, not done in Sheba, but just something to think about. One of the therapies that I spoke before was BCL receptor inhibitors. It's a BTK inhibitors. And this drug is also used in patients with chronic GVHD. This is inflammatory response in patients undergoing allogeneic stem cell transplantation. And it reduced the inflammation. This therapy, this medication is also in clinical trials, actually phase 2 clinical trials in not CLL patients, in COVID-19 patients. And this is due to this effect in reduction in the inflammatory immune response to the virus. So this is something else regarding CLL therapy and COVID, and I will be happy to take questions, and thank you. And I'm sorry that you didn't see the slides. And share.
think that I should
I know,
thank
I
you
see
for
you.
participating. I think that I should answer. I should thank you for your interesting speech. Can you hear me?
Yes, we can hear you,
hear
Nomi.
you. Just there was a long silence, so.
Okay. Now, how are the thing is on top of it?
Okay.
Thanks. Sorry, so they were talking about, couldn't you in fact change the atomic structure of a virus? Is there a possibility that we could use things like the Large Hadron Collider, asked Guillermo Lapidus, to change the atomic structure of viruses or the proteins and use quantum biology in the fight against disease?
So if you're speaking about the COVID, I'm more in fighting cancer cells. Actually, I don't know the answer for this.
Okay, good. Appreciate it. Ohad, thank you for joining us this evening. We're so
I'm
sorry
sorry
that
for the slides, and if someone wants a personal talk, I can deliver later.
Not a problem at all. I know we've run really long. We've gone on for 2.5 hours tonight. Our apologies for that. That was never our intention. But when we have breaking COVID news, that really is international breaking COVID news on an issue like Ivermectin, which is so important to so many South Africans. Forgive us that we've inserted that at the very last minute into this evening's production. With that, we just want to thank everyone who's listening. We still have over 1,000 people who are tuned in at this moment after 2.5 hours. And thank you for your staying power. We'll see you on Saturday evening with our webinar relating to leadership and culture and strategy. But we want to also give you one last opportunity before we leave. We want to give you one last opportunity. If you want to make a donation through to Sheba, please feel free to either on YouTube, click on the link that Danny has posted into the chat on YouTube, or alternatively on the poll that is put up in Zoom at the moment. If you'd like to make a donation, please feel free to do so. No obligation whatsoever. But thank you so much for joining us this evening. We will see you on Saturday evening again. Have a very good night.